This presentation was recorded at the 2015 Gold Coast ANZICS Safety and Quality Conference on Deteriorating Patients.
Thank you for having us both here. For starters, I need to apologise for my voice. It decided to abandon me on Sunday, and I've done every known drama trick to recover it, and it's not done particularly well. I'm very glad I have a partner in crime, so you don't have to listen to me croak through for the next 15 minutes. As was just mentioned, I became involved in the development of the QMEWTs a couple of years ago. Initially, we had adult deterioration forms introduced, and we very quickly realised that for the maternity setting, that wasn't meeting our needs, and that we needed to look a little bit more specifically in the scoring that we were doing around our observations. It was a big statewide development. It caused quite a bit of discussion. As midwives, we tend to be a fairly unique bunch. We have our own ways of practicing, and we hold on to, I see some chuckles at the back there, we tend to hold very firmly onto the idea that midwifery is normal. We like to keep birthing normal. However, we also need to step into the realisation that our women and their demographics are changing. And because of that, we're also having to move forward with the observations that we do, with the introduction for us of national standards. We needed to introduce how frequently we did observations, and there's been quite a dramatic change over the last few years about how we've done that. We're going to have a very brief look at quite a few things that are involved with our deterioration, and I'll let Brittany start off with some of our clinical considerations.
So basically just starting to go through some of, again, we only have the Queensland statistics, but as you can see, given the demographics and the changing nature of the community, our increase in maternity services is dramatically increasing as well. So we can see from Queensland, there was 73.2% births in the public system back in 1996. Although that looks like that's actually going down, it's because the private sector is starting to increase as well. But back in 1996, 69% of those were vaginal births, and again, we're considering those to be more low-risk patients versus 21% caesarean sections, which are now, again, as the public starts to increase, as the private starts to increase, the caesarean rates are also subsequently going up. Which can complicate some of our women, some of our outcomes at the end. So basically obstetrics and gynecology as well is one of those areas that, again, when I speak to a lot of my colleagues, you either love or hate. I would say there's no real in-between and there's no middle ground. So maternity and birth suite tend to be over towards one side of the hospital, and if you belong there, you stay there, and if you don't, you don't. And there's no kind of crossover. So when we look at the ICU, again, given we are a smaller hospital, when we look at the tertiary centres, these are obviously going to be quite large numbers. But back in 2007, there was 142 admissions into our ICU unit, and 7% of these were maternity related. Again, over the years, this has slowly started to increase, but substantially we can see that over those last 7 years, the maternity related admissions are also steadily increasing. Majority of our patients that end up in ICU mostly go for things like preeclampsia, where they're needing their fluid monitoring quite closely. Postpartum hemorrhages, again, fluid volume and depletion needing to be monitored with invasive techniques, as well as anaphylaxis tends to be a big one that we run into. Majority of our patients are healthy women, well women, so we're not expecting them to need those services. But the things we need to remember is that pregnancy in itself has a lot of clinical considerations. So there's a lot of haemodynamic changes that are related to pregnancy, and most well women can tolerate these without any concern. Again, cardiac output increases by about 15 to 50%. They say that by the 6-week mark, about 50% of the cardiac output has increased compared to a non-pregnant lady. Resting pulse and stroke volume are increasing. There's increased diastolic filling and decreased systemic and pulmonary vascular resistance due to the uteroplacental interface. So these are, again, going to be more pronounced in multiple gestations. And given the populations that we're seeing, with a lot of women having comorbidities prior to falling pregnant, the increase in diabetes and hypertension and obesity is going to complicate these factors even further. A lot of our women are on multiple medications, they're seeing IVF specialists, they're becoming pregnant when potentially nature may not have allowed them to prior, and we're needing to try and optimise them prior to their pregnancy to try and reduce the risk and rates of these deteriorating patients. So intrapartum, again, there's an order transfusion of about 300 to 500 mils of blood from the uterus, and sympathetic stimulation, which can be associated with the pain of labour as well as anxiety. And again, postpartum, there's an immediate rise in cardiac output as the increase in venous return with the release of pressure off the IVC once the gravid uterus is emptied. So again, clinical considerations, as we mentioned before, there's the comorbidities associated with these women who are falling pregnant, again, potentially at later ages, with comorbidities like Crohn's disease and renal transplants, that we need to get the multidisciplinary team to become involved with their care to try and limit their potential complications. The risk that we see as well is that many of our patients do not purely exist in birth suite or do not purely exist in the postpartum ward. So they get taken to theatre, they come in through ED. Again, there's problems that we see in the corridors and in the bathrooms, and getting the MET teams down to our wards is sometimes more of an issue. So we're used to managing our women. We're used to seeing that if they have a heart rate of 50 and a blood pressure of 90/60, that may be normal for them because they were a healthy, fit woman prior. But these women, because they're able to clinically compensate for so long, may not actually exhibit the signs that we expect from women who are in hypovolemic shock. So they don't exhibit the tachycardia associated with this decrease in blood pressure until they're really, really, really at the end of their tether. The other problem we tend to run into is that unfortunately and fortunately, a lot of our wards are run by junior staff, which again is a hospital-wide issue that we sometimes face. I remember my first day as an intern on the O&G ward having a MET call and just being beside myself. The registrars were all scrubbed, the consultants were all scrubbed, and now somebody that you think is dying in front of you and you don't know what to do. So again, you call for help, but it feels like the longest 3, 5, 10 minutes until the MET team can get there. And majority of the time, when they come, there may not be an issue, but it's getting our junior staff aware of the differences between our maternity patients and the general population, as well as the similarities.
So also from the ward perspective, as Brittany said, women compensate for such a long period of time that we don't see any changes until the very end. We usually, during the daytime, have our ward residents, and they're our first people that are called on. And as Britt said, there's quite a high frequency that the resident is the first person that is left to manage. Once we manage to call a MET call, we're also attempting to contact more senior registrars and consultants. So at the same time, we've got 2 different teams coming in to manage a situation, which becomes extremely overwhelming, not only for the woman and her family, but also the rest of the staff. You find that on quite a frequent occasion, you're repeating the same story more than once, and I think that's something that we certainly need to learn and do better with. So, as I said, about 3 years ago we started to work on the QMEWT. We do have some slightly different parameters. For Logan, we would look after women anywhere between 14 and 40. So in reality, we're also dealing with people who would quite often be in the paediatric section. So there's considerations that we need to take into account from that side as well. We need to consider quite strongly whether a woman's status is normal for her in a pre-pregnant period, or whether it's a pregnant complication for that individual. as well as then our usual considerations. So certainly clinically, a loss of consciousness is a fairly obvious sign that there's a deterioration. But with blood loss, the deterioration can be quite significant, but with the compensation not actually show that there's any issues. Sepsis is something for us that then adds a couple of different dimensions. Yesterday, a couple of times it was mentioned about paediatric factors. Particularly for a woman who becomes septic in the first 24 hours, our responsibility then not only relies or not only falls on the obstetric team to manage, but we also have to bring in the paediatric team. We need to take into account that there's a possibility that that septic condition was actually in place prior to birth and that the neonate is also at risk. So there's dual factors that we also need to keep in the back of our mind quite a lot. Good old communication. So this typically for us is also an issue. As I said, our residents are there first and foremost. They do the very best they can, usually with not very much information. Our residents are very much designed to look after our discharges. Their priority first and foremost is to get that movement through the unit. Just like any other area, we've got our discharge targets and timeframes. Well, women are expected to be staying in hospital for less and less time. We certainly don't meet particularly good averages. We're about 1.7 days for a normal birth. However, our Caesars are moving through extremely quickly. They're averaging about 2.6 days. So the time frame for those people is quite significant. So you can imagine a resident with not very much information other than a discharge list suddenly being hit by a MET call, having two teams of medical staff, ICU staff and everybody that's on call for our MET teams arriving, demanding information. It's a fairly overwhelming experience for them. As Britt said, our environments for managing obstetric emergencies vary quite a bit. We obviously have the ward. Our often first port of call after that is birth suites. So we try not to refer directly to our ICU. If we can manage it in birth suites as a special situation, then we will do that. We find that way we're able to maintain a more family-friendly environment. We can keep babies and mums together. If a mum needs to go to ICU for continued care, then the mum and the baby get separated. The emotional impact of that then often has a flow-on effect to the rest of her physical recovery and the trauma for the rest of the family, expecting what should have been what was anticipated to be a normal birth episode is then split with people in different directions. The mention of a baby being in a special care nursery is also quite a frightening experience because they think then the impact is that the baby is going to be unwell also. It's more that the mum just isn't capable of caring for that baby at that stage. Okay, so challenges for us are obviously streamlining our escalation processes. There has been a review of the QMEWTs and there's been a few other factors added into that side. We needed to come into line with adult deterioration, so pain scores, loss of conscious, those types of things. However, as I mentioned, midwives being midwives, we don't always embrace those changes particularly well. So for Logan, we tend to do the general observations particularly well. I've been quite lucky being involved. We were able to promote their development and also the importance of doing those observations right from the beginning. However, I know for a lot of the smaller areas and other areas in the state, the idea of even doing 8th-hourly observations for obstetric women is I guess a step that they don't even want to embrace at this stage. As I said at the start, with midwifery being a well, normal experience. The idea is that if women are well and seem to be normal, then other than the first set of obs at the first couple of hours after birth, then nothing else needs to be done, particularly when we're promoting 6-hourly discharge. We've tried to promote the fact that if you're not doing anything, how do you actually know that there's a deterioration? We are promoting very heavily the fact that at the end of the day, along with themes that were mentioned yesterday, we're there for our women. Our women and families need to be put first, and if we're actually not looking at what is happening for them, how do we know the changes that we need to make? I might let Britt talk about the last part, which is orientation, because that's certainly a medical factor. From the nursing side, with a general hospital orientation, our staff are all introduced and ADS charts and our QMEWTs are explained to them. However, what we don't do particularly well is a multidisciplinary team orientation. So, to this day, I couldn't tell you in great detail what the obstetric team or the paediatric team are orientated in, and I'm sure that other than the general district side orientation, that Brett and the other medical staff would probably feel very similar about what midwifery staff do, and I think that that's probably an area that we need to look at quite a bit more closely. If we're going to work together in teams, we need to be very well aware of what the other side are each told about.
Exactly. So as Karen was saying, orientation tends to be one of those topics that we can talk about, but until we actually do, it doesn't really have any benefit. So again, as we all know, starting at a new place is always a bit daunting and anxiety-provoking. However, saying that, especially the junior medical staff, they get rotated through many of their rotations every 5 to 10 weeks. So in terms of doing obstetrics, if you haven't done it before, it's a really daunting experience. Going from a medical or a surgical ward, from respiratory to gastro, the patients tend to be fairly similar. But if you haven't done obstetrics since third year of med school and all of a sudden are put back into the postpartum ward, if you haven't seen that a blood pressure of 140/90 isn't normal and needs to be acted upon immediately, it's something that you tend to kick yourself about in the future. Why didn't I realise this? Why didn't I know this? And again, it's the little subtleties that sometimes we miss for our junior staff who have a lot resting on their shoulders. Changing of locations, again, as registrars, everybody's changing quite often, so it's quite easy to, or quite hard to figure out who is the best point of call, who is the next person to go to, how do we get things rolling if there is an emergency situation, even silly things like carrying a MET pager. At Logan, unfortunately, the MET pager goes to the ICU anaesthetics, medics, but not us, so we sometimes are lost to know about our MET calls on the obstetric ward. We do have an on-call phone, but if we're scrubbed in theatre, it's really embarrassing when we get there after everybody's already there. So I guess it's highlighting that we are a multidisciplinary team. We need to be a multidisciplinary team for the women, their babies, their families, and we need to make sure that given the demographics that are changing, given the population that we have in front of us, we need to make sure that we try and optimise the care for these women for the best outcomes possible.